to kind of talk about osteoporosis today, and it's an important topic and has just such a big impact on so many people's lives. Starting off, bones. I'm an orthopedic surgeon, so I love bones. I think they're fascinating, and I love fixing them. Love working with the material. Bones are actually a living tissue, so they're made up of collagen, calcium phosphate mineral crystals, and they actually evolve over time. So we know that when we're young like you, the ends of your bones have growth plates, and so they increase in length and we get taller. And we also store calcium and minerals over our life, and what they call the peak bone mineral density is reached somewhere between the ages 18 and 25. And so we work to store as much density in our bone as we can and then maintain that over the rest of our lifetime. So once again, bones they're not a static structure, they're continually being churned over. And so how does that happen? Well, we have little osteoclast and osteoblast. And there's a balance that occurs where that bone is being remodeled, the osteoclasts go in and chew it up, and then on the other side, the osteoblasts go along and lay down new bone. And I think that's one of the most dramatic demonstrations of that is with pediatric fractures. And so this is a femur fracture in a 9-year-old, and it's treated with cast immobilization. And you'll see that over time, over 15 months, the bone actually remodels and straightens itself out. Wow. And it's usually kind of a tough sell to the parents when you have them in your office and you say, we're putting this in the cast, and I promise in a year it's going to look a lot better and it's going to remodel itself. And it's only after you get these later x-rays that they kind of see the end results. So what is osteoporosis? It's the breakdown of the building and getting out of balance, and the bone becomes weak. And they call it a silent disease because unfortunately a lot of times the first time people receive the diagnosis is when they have a fragility fracture. And I think Daen has a couple. We're going to pass these around. These are actually computer models of actual bone, some normal bone, and then some osteoporotic bone.
These are actually from the same person.
And what one thing with my job is I have the ability or pleasure of working with a number of different people and their bones, and it's amazing the difference in quality. And when you're working with someone younger, it's dense. We often have to use taps to get our screws to go in just because it's so solid that it'll actually sometimes break the screws unless we pre-drill it. And then when we get into some more of our osteoporotic patients, it's almost like eggshells. And sometimes to the point where you can actually take your thumb and push into the bone, or we're trying to put screws in the bone and hold our fixation. It becomes very difficult when we don't have the bone mineral and mass to help us along. So once again, fragility fractures, most commonly the ones that we're tracking are the ones in the proximal humerus, the distal radius, the femur. So you'll see over on the right, this is a proximal humerus fracture, and on the left, a femur fracture. So what are some risk factors for weak bones? As we age, I said before, we kind of hit that peak bone mass at around 18 to 25, and then we start spending our currency over our lifetime. And so we're trying to maintain as much as we can over our lifetime through good diet and exercises. Genetics play a part. If you've got a relative who has a fragility fracture, then you're at risk. Menopause, certain medications, in particular corticosteroids, being on those for a prolonged period of time can put you at risk. radiation, parathyroid or thyroid disorders, kidney disease, and diabetes. Some of the things that we can control our alcohol intake. The recommendation is no more than 2 drinks a day. Smoking, lack of exercise, and lack of vitamin or mineral supplementation either through our diets or through the supplements that we take. So it's the Own the Bone program, the way it came about, it's kind of interesting. The orthopedic surgeons are kind of known for being kind of big, dumb athletes and not always being more the carpenters and less of the primary care docs who kind of follow things and medications over time. But we were finding as especially that a lot of our patients were coming in with a hip fracture, and we'd do a great job fixing their hip fracture. And then 6 months or a year later, they'd fall down and break their hip on the other side. And while that's good for business, it's not the best thing for our patients. And so healthcare is changing a lot. We're putting a lot more requirements on our primary care docs. There's a lot of things that need to happen during that visit. And we were finding that the treatment of osteoporosis, the bone health, just was kind of slipping through the cracks. It's a very prevalent problem with over 2 million fragility fractures in the U.S. each year. It's a devastating problem that 25% of the patients who suffer from a hip fracture will die within 12 months. And that isn't necessarily from surgical complications. It's just more of a marker that, there's other things going on with the body, but it's fairly significant. And 20% ending up in a nursing home. So these are life-changing events for people. Up to 50% of women and 25% of all men over age 50 will sustain fragility fractures in their lifetime. And when I said slipping through the cracks, this kind of demonstrates that fragility fracture is the most common cause of fracture among seniors, yet only 20% of patients receive what we consider best practice care. And so if you look, it's a little hard to see, but our pie charts up there, we have treatment for heart attacks, breast cancer screening, and colorectal cancer. And we're doing a pretty fair job of taking care of our patients when you look at the percentages. But in the end, when you look at osteoporosis, only 21% of those patients are receiving what we consider best care. So we're really missing the mark. And so what this Own the Bone program is, and what our efforts are, is trying to go out and identify those patients who have sustained fragility fractures and get them into a program where we can prevent any further fractures. Those of you sitting in the audience too that weren't standing up, we also like to take the patients who are at risk, and after talking to their primary care doctor, if they want to go on for further counseling so we can prevent some of these fractures, we want to provide that service also. So we are now the only Own the Bone site in Montana, and a lot of our recommendations are evidence-driven. That's kind of a big buzzword in medicine nowadays. And what that means is we're collecting data over a large number of patients and seeing what works and gives us the best outcomes. And as part of an Own the Bone project, we're actually also collecting data on all of our patients to dump into the big pool so we can get better results. And the biggest part of this is really communication, and it's allowing those patients who are in the hospital to not only get their fracture fixed, but have follow-up with their primary care doctor and also with our nurse practitioner so that they get on the right track to prevent any further fractures. And so with that, I'm going to let Daen Scott take over. She's been an addition to our team, and she actually works in our office. And so it's been in the orthopedic building. And so when people come in for their post-operative visits, we try and make it a one-stop shop so that they can also meet with Daen and make sure that we're doing everything we can to maximize their bone health. So I'll turn it over to Daen.
Thank you, Dr. Schmidt.
So we're going to walk through some of the 10 measures that the Own the Bone program recommends today, because I think it's really important to note, first of all, I'm actually really happy to see these statistics about how poor the follow-up tends to be for osteoporosis after a fracture. Apparently in Billings we're beating the odds, because those of you that were standing, we had a little bit better than 1 in 5 percentage, so that makes me happy. Nationwide the statistics still aren't great, but we're working on it. So yeah, our goal here at Billings Clinic is to provide integrated care to make sure that we are communicating between the specialists, between your primary care doc, and with you, so that you know what you can be doing to maximize your own health. So we're going to kind of walk through the Own the Bone guidelines today. We're going to go through all these in much more detail. Don't worry, you don't have to read that fast, I promise. Okay. We're going to start with kind of what I consider the most obvious one. I think most people know calcium's good for bones. We've all heard that. But the question I get asked very frequently is how much? What kind? You go to the pharmacy and there's 5 million varieties on the shelf, right? And one day calcium everyone should be taking, and the next day the news says, oh, don't take calcium pills. They're bad for your arteries. So here's the current guidelines. We want at least 1,000 milligrams per day for men over 50, 1,200 a day for women over 50, or really any woman who's post-menopause. Younger than that, it's about 800 milligrams a day, if anyone asks. But you can see there's a pretty big safe range. Okay, up to about 2,500 a day is considered probably safe for most people. But that's not all from a pill. I think that's the key point, is you have to have a rough idea how much you're getting from your diet, because this is total from everything that goes into your body. For example, if you're a dairy eater, most servings of dairy, whether it be milk, cheese, yogurt, cottage cheese, roughly have about 300 milligrams of calcium in them. So if you get 4 servings of dairy a day, you might not need a supplement, okay? So the best thing to do, there's a lot of good resources out there, you can get them from your healthcare provider, is to kind of get a rough estimate of what your daily intake is. You don't have to tack it on the fridge and log it, we're not counting calories here, okay? But get a rough idea where you're at, and that'll give you an idea of how much calcium is appropriate for you as a supplement, all right? Most people I find, if you buy a bottle of calcium, they usually say take 2. Well, that gives you that whole 1,200 on most brands, okay? Most people get about half from their diet and only need about half from a supplement. So just kind of pay attention to it, and if you have questions, best thing to do is bring the bottle in with you to your next appointment so you can show them what you're taking, okay? I don't know about you, I can't remember what the label says either once I'm in the office. So the other thing I wanted to touch on briefly is calcium carbonate versus calcium citrate. These are the 2 most common forms we see in over-the-counter supplements. Most of the stuff you're going to buy is going to be calcium carbonate. Why is that important? For many of you, it probably doesn't matter, but calcium carbonate is going to be best absorbed with a meal. You take it on an empty stomach, you're probably kind of throwing your money away. You're not going to break it down without stomach acid. And on that note, if anybody's on anything for heartburn, like Prilosec, Zantac, Prevacid, anything you take every day, you don't produce enough stomach acid to break that down. So calcium citrate, it's more expensive. Most common brand name is Citracal, but there are a couple others. It breaks down a little easier. So that's probably going to be a better bet for you. All right, vitamin D. Nationwide, the recommendation is somewhere between 800 and 1,000 international units of vitamin D a day. Quite frankly, for most people in Montana, that's not enough. So this is another, you're going to hear me say this a lot, but it's without knowing you individually, it's hard for me to give specific recommendations. Talk to your primary care provider about whether getting your vitamin D level checked is appropriate or what level they're comfortable with you taking as a supplement. Most people in Montana are vitamin D deficient simply because we live far enough north that 6 months out of the year, the sunlight doesn't actually help us manufacture any in our skin. So I will tell you in my personal clinical experience, I have yet to run a vitamin D level on a patient that wasn't already on pills that was not deficient. It's not a very scientific study, but it's what I've seen. I have a lot of patients that are on very high doses of vitamin D also, because if you have, if your body weight's higher, you might need a little more. If you're healing a fracture, you're almost definitely going to need more because your body's using that. So, other things, we already talked about the heartburn medication. If you're on heartburn medication, you're at higher risk for osteoporosis because you don't break down calcium very well. My fellow diet soda drinkers or regular soda drinkers, yeah. So colas actually have phosphoric acid in them, and high phosphorus levels can leach calcium out of bone. So there are some studies that link a little bit of decreased bone density to high cola intake. I'm not going to tell you you have to get rid of it, but 1 a day instead of 6 a day, probably better for the bones. Caffeine doesn't really directly impact bone health, but it does make you use the bathroom more, and it might make you lose more calcium out of the kidneys. So if you're a coffee hound, again, you might be at higher risk. You might want to be a little more aggressive in getting your bone health assessed. All right. If I can say anything about long-term health, and I'm going to step off the topic for a second, long-term health in general, longevity, quality of life, bone health, weight control, which is the other half of my job, sorry. Move. Keep moving. And I'm not talking marathons here. I'm not talking, gold gym modeling here. All right. I'm talking just using the whole bone and muscle, or use it or lose it. They're expensive to maintain. Okay. And I don't know about you, but if I was writing a check every month for a service I didn't use, I would cut that out of my budget, right? Well, the body's the same way with its resources. The body has limited resources, and it's not going to maintain anything it doesn't think it needs. So if you're not putting some weight on those bones and muscles every day, they're going to get weaker, okay? Walking's great exercise, and I definitely, if you're able to tolerate walking, that's a great way to maintain most of your skeleton, but don't forget about those arms. As Dr. Schmidt pointed out a couple of times, proximal humerus fractures are one of the more common osteoporosis fractures, which that's right here, by the way. So what happens? You fall, you go to catch yourself, okay? So maintaining muscle strength, upper and lower body, really important for long-term health. So please keep moving. And if you have problems, health problems that limit how mobile you can be, bring this up to your healthcare providers. Do you need some physical therapy? Do you need, those guys are experts in this stuff. They can help you understand what exercises are safe for you. There are sit and be fit programs that are very effective, and it can just really help maintain that quality of life for you. Speaking of falls, it's a lot easier to keep a bone from breaking if it doesn't hit cement, right? Make light of this, but it is one of the most important things we can do. This is really individual. Some people are more at risk for falls than others. And it's not just age related. It can be related to eyesight. If you have poor eyesight, you're at risk for a fall. If you have balance issues or neurologic issues that make it hard to feel where your feet are on the ground. If you have medications that make you drowsy or make you dizzy when you stand up. Really paying attention to those things and really having an honest conversation with yourself and your doctor about your risk. Because when it's time to maybe put some grab bars in the shower, or make sure that your house has good lighting, make sure that those carpets are tacked down well, let's do that before the fall happens, because the longer we can keep you independent, the better off you are. And this is actually an interesting one. Getting your eyes checked does help prevent falls, but be careful right after a new prescription, because even though your eyesight's better, the fall risk actually goes up. And we're not really sure if that's because you're getting used to the new glasses or because of the just the fact that you're moving more when you can see better. And Tai Chi, really good for fall risk. Just for something new and different, a healthcare provider is going to tell you to quit smoking. seriously, we all know the health risks of smoking. Let's just add this one to the list. If you do smoke, it is toxic to the bone. You are at much increased risk for osteoporosis and fractures long term. This was already mentioned, alcohol intake. And the guidelines are a little bit varied. One organization says 3 a day is okay for men, 2 for women. The American Association of Clinical Endocrinologists actually says no more than 7 per week for women after menopause. So a glass of wine with dinner is fine. A glass. Okay. Okay. So let's talk a little bit. We've mentioned a couple times that if you come to see me or you talk to your primary care provider, we're going to want to do some testing. Well, what kind of testing? Number one thing we need to determine fracture risk is a DEXA scan, dual energy X-ray I can't even say it. It's a DEXA. We have these little shorthands for a reason. Don't let us fool you. All right. Medicare does cover these as standard testing, and most insurances will as well. Standard recommendation across the board is everyone pretty much after age 65, but if you're younger than that and you have risk factors, talk to your doc, because we may want to get one as early as your 40s or 50s if we think you're at risk, okay? What we do is we get a measurement of the bone density in your hip on both sides and the lower spine. Sometimes they do a forearm, sometimes they don't, but that allows us to get a rough estimation and plug it into this scoring tool that gives me an idea of how at risk are you over the next 10 years to have a fracture. And that helps us guide our decisions on whether it's, worthwhile to get you on medication, whether we can just do calcium and exercise for a few years. That's a very individual decision, because all medications do have risks, but the sooner we make sure we're holding on to that bone, the more bone we're going to hold on to. Okay. And this is just kind of this is an example of what a DEXA looks like. I just put that on there because I think they're cool. Okay. So who should go on medicine for osteoporosis or osteopenia? If you've had a spine or hip fracture because of fragile bones, it's time to go ahead and do medication, okay? You are considered high risk regardless of what the DEXA says. When we get a DEXA back, we get what's called a T-score. And what that is basically the World Health Organization gathered data from thousands and thousands of people and kind of figured out where some logical cutoffs for risk are by comparing you back to the bone of a healthy 25-year-old, okay? So if your T-score is 0 to 1, we consider that normal. Everything's great. If it's between 1 and 2.5, that's where we get that term osteopenia, which is medical speak for gray area. We have to look at everything else to make a decision, okay? If it's below 2.5, you are at increased risk for a fracture. You have osteoporosis. We probably need to act, okay? I have seen these as low as -5, which was obviously post-fracture. And then there's some, again, with the FRAX scoring, if we think your hip fracture risk over the next 10 years is above about 3%, we usually go ahead and treat, because hip fractures can be so disabling. We want to go ahead and be very aggressive with preventing that. Okay, so through the Own the Bone program itself, part of my job is to communicate with your primary care provider, okay? Once I talk with a patient and we do testing, to evaluate, not only do I do a DEXA scan, I also do blood work to see, as we talked earlier, about some of the other causes. If you have a thyroid disorder, that can affect your bone. If you have a parathyroid disorder, who's ever heard of a parathyroid disorder? A couple people, cool. All right. If you have a parathyroid disorder, that can affect the bone. If you're vitamin D deficient, that can affect the bone. If you have undiagnosed celiac disease, that can affect the bone. We test for these things. The goal is to communicate back to your primary care provider so that your follow-up and care do not get lost in the cracks, all right? My goal today is to give you some questions to ask your primary care provider. If they're comfortable managing this for you, fantastic, okay? Honestly, I don't need the business, I'm good, all right? But if they're not, have a chat about whether our program's appropriate for you, okay? In men, testosterone deficiency can contribute to weak bones. And that's just kind of some info. Those of you coming to us on telemed, we do telemed, both in Montana and Wyoming for this. But basically, if you're over 50 and you've had a fractured bone that wasn't the result of a car accident, and I'll be honest with you, I have a lot of folks say to me, anyone would have broken a bone slipping on that ice and falling down. I want you to think back how many times in your life maybe you slipped and fell without breaking a bone. If you've had a broken bone from anything that wasn't a significant trauma, you need to talk to your primary about this if you haven't already.